this video, I will explain the stepwise approach to investigation in neonatal jaundice. This will help us to decide which tests to do, in what order, and why, so that we can identify pathological jaundice early and prevent complications like kernicterus. Jaundice usually become apparent in a cephalocaudal progression, starting on the face and progressing to the abdomen and then to the peat as serum level increases. Face demonstrate 5 mg per deciliter bilirubin, mid-abdomen demonstrate 15 mg per deciliter, and peat and salt show 20 mg per deciliter bilirubin. Kramer's criteria is not 100% correct, but it gives a clue to evaluate serum bilirubin. Lemon yellow jaundice caused by unconjugated or indirect bilirubin. It is commonly seen in physiologic jaundice, breastfeeding jaundice, and hemolytic disease like Rh or EBO. Unconjugated or indirect bilirubin responds well to podiatropy, which converts bilirubin into water-soluble form or direct forms. Orange yellow jaundice commonly indicate conjugated or direct bilirubin. This is seen in conditions like neonatal hepatitis, biliary atresia. Phototherapy is not effective in conjugated bilirubin because it's already water soluble. These babies may have dark urine, pale stools, and hepatomegaly. Neurotoxicity risk factors. This is such important things that we should know about it. In isoimmunization and G6PD deficiency, red blood cells break down rapidly, causing a sudden rise in bilirubin. When albumin is less than 3 grams per deciliter, bilirubin cannot bind properly to albumin, increasing pre-bilirubin, which can cross into the brain and causes kernicterus. Preterm infants have an immature liver and immature blood-brain barrier, so even lower bilirubin levels can cause damage, sepsis, hypoxia, and clinical instability. Increased blood-brain barrier permeability and also weaken bilirubin albumin level, raising the risk of kernicterus. Jaundice is pathological if it appears in first 24 or 36 hours, rises more than 5 mg per deciliter per day, exceeds 12 mg per deciliter in term infants, and 10 up to 14 mg per deciliter in preterm infants, and lasts longer than 10 to 14 days, or if direct bilirubin is more than 2 mg per deciliter at any time, or 20% of total bilirubin. Pathological jaundice. The baby have dark urine, pale stools, and hepatomegaly. The key message is early onset, rapid rise, high level, prolonged duration, and direct bilirubin. These are dangerous and pathological. Determine the cause of jaundice if stepwise approach to neonatal jaundice. We start with the most important and mandatory investigation: total serum bilirubin with fractionation into direct and indirect bilirubin. This confirms true hyperbilirubinemia and tells us whether the jaundice is conjugated or unconjugated, which is the key decision point in neonatal jaundice evaluation. Decision point: physiological or pathological. At this stage, we assess whether the jaundice is physiological or pathological based on age of onset, level of bilirubin, rate of rise, clinical condition of the baby. If the jaundice is physiological, no further investigation are required and we continue observation. If it's pathological, we proceed further. Step 2: blood group and direct comb test. The next step is to check the mother's and the baby blood group and perform a direct comb test. This helps us identify ABO or Rh incompatibility, which causes immune-mediated hemolysis and is a common cause of early, severe unconjugated hyperbilirubinemia (ABO). This condition becomes when the mother blood group is O and the baby blood group is A, B, or AB. Rh incompatibility becomes when mother blood group is Rh negative and baby blood group is Rh positive. These conditions causes immune-mediated hemolysis and increase in bilirubin level. Third step is CBC and reticulocyte count. Lower hemoglobin level and increased reticulocyte count. This suggests an ongoing hemolysis, while peripheral smear may provide additional clues to the causes. Step 4: G6PD screening. G6PD causes oxidative stress, leads to rapid RBC destruction, and it causes sudden rise in unconjugated bilirubin. G6PD screening should be done in babies with severe jaundice, poor response to phototherapy, or relevant family or ethnic background. G6PD deficiency can cause sudden and severe hyperbilirubinemia even in otherwise healthy neonates. Decision point: at this point, we reassess the baby. If the baby is sick or if the direct bilirubin is elevated, we shift our evaluation toward infection or liver-related causes. Sepsis screening, including CRP and blood culture. Liver function tests such as AST, ALT. Conjugated jaundice is always pathological and requires urgent evaluation. If the baby is otherwise well but jaundice is prolonged, more than 40 days in term and more than 21 days in preterms, we evaluate for thyroid function test, UTI, metabolic or genetic disease. Abdominal ultrasound is done when there is suspicion of biliary obstruction, hepatomegaly, or pale stool. Early detection of conditions like biliary atresia is crucial for timely surgical intervention. Persistent indirect hyperbilirubinemia suggests hemolysis, G6 deficiency, breast milk jaundice, hypothyroidism, and intestinal obstruction.